Hi guys, welcome back to Codemaster Coach, your medical coding tutor. As promised in my last video for risk adjustment, I told you I would come back with the chart components for risk adjustment. So I want to continue that study. And just remember, when we're looking at the chart components, we're looking through physician documentation because as a risk adjustment coder, we're looking for diagnoses. And who diagnoses your patient? Our physicians. So let me give you some chart components for risk adjustment. All right, chart components. First is your chief complaint. The chief complaint is a statement by the patient regarding the reason for today's encounter. For example, I am short of breath. I need a flu shot. My prescriptions have expired. So, is the chief complaint subjective or objective? And may this be coded? And I put a note over here on the side that said subjective originates with the patient, but objective originates with the physician. So with the chief complaint, the patient's coming in and they have a complaint. Is that chief complaint subjective or objective? So then the question becomes, can it be coded? What about the history of present illness? History of present illness is a chronological description of the development of the patient's present illness from the first sign and or symptom or from previous encounters to the present. Usually it contains information pertinent to coding and may contain some diagnoses that are not listed in the assessment or plan. So is the history of present illness subjective or objective? Review of systems. A review of systems is an inventory of body systems obtained through a series of questions to the patient, often in a sheet that the patient is asked to fill out before the encounter. Not usually a good source of abstraction, but may list signs and symptoms that support diagnoses from the physician. So is the review of systems subjective or objective? Past family and or social history. The past family and or social history is the patient's past illnesses and surgeries. The patient's recollection of the family hereditary or other diseases and a history of contributing factors, for example, the patient's marital status, their smoking history, and or drug or alcohol use. So, is the past family and or social history subjective or objective? Physical exam. The physical exam is a visual or tactile examination of the patient by a physician, which may focus on all or a subset of anatomical systems. The level of detail of the physical exam is at the discretion of the physician and is based on symptoms or disorders for which the patient is being seen. So, is the physical examination subjective or objective? The assessment plan. An assessment plan is a list of the diagnoses assigned to the patient and the treatment or diagnoses or diagnostic testing being performed to monitor the patient's condition. It's usually listed at the end of the encounter, and the assessment may not be integrated with the plan. So the coder may need to infer which test is being ordered is for which diagnoses. Now you have what's called SOAP notes. I can remember one time we tried to get our physicians to document in the SOAP note format because SOAP notes give greater detail. SOAP notes lead you with a subjective, objective, assessment, and plan. If physicians could just document that thoroughly for us, it would help us find diagnoses and know exactly what's being treated, because the subjective, it says here, is a brief narrative of the patient's chief complaint, including the history and symptoms associated with the complaint. So in this case, the subjective was a sudden onset of right shoulder pain following a slip and fall on ice last week. But patient had mild chronic right shoulder pain for 2 years with the diagnosis of chronic rotator cuff injury. And sleep following the fall has been difficult due to exacerbation of the shoulder pain when laying down. So see how that's a subjective. It's describing subjectively what's wrong with your patient. Objective is your physical exam and testing to determine your patient's condition. This is where your physician prescribes any type of testing. He orders testing or something to figure out what's going on, what's wrong with that shoulder. So before the encounter, the patient underwent an MRI and what the MRI showed, and based on the lab results, what it's all showing. So that's your objective. Your assessment is the physician's determination of the diagnosis. Here, he's diagnosing your patient. He's saying this patient has acute on-chronic rotator cuff tear. He found that out based on the testing that he did. And then your plan, his plan is to treat the patient. It says we'll be undertaking to correct the patient's problem. In this case, he gave the patient, he's agreed to begin ibuprofen therapy, and today received a cortisone injection. Okay, so see, that's the plan. It says shoulder surgery was discussed for possibility in the future, but that the short term, the patient wants to see how his shoulder responds to the pain medicine and the cortisone injection. So you see how it went from subjective, hurt shoulder falling, objective, physician ordered lab tests and assessment, based on the results, based on the patient's complaint, what does the physician think is wrong, acute on chronic rotator cuff tear, and then the plan, how he's going to resolve it. Boy, we get physicians to document like this. You also have behavioral charts in certain settings, and it just takes you through 5 different axes. It talks about different types of conditions such as acute clinical disorders, major depressive disorders, personality disorder, avoidant personality disorder, general medical conditions such as alcoholic cirrhosis and hypothyroidism. These are behavioral health issues now. Psychosocial environment, smoker may live alone. Disability assessment. With the disability assessment, there is no actual performance here. But again, that's for behavioral charts. And just risk adjustment coders tips. It says verify the patient by checking the name and date of birth against the file's demographics. Go to the inpatient discharge summary. That's where I always start when I do my coding. When I'm doing inpatient coding, I start with the discharge summary because usually that's a summary of the stay. And review the chart for proper signatures and then skim the entire chart for additional diagnoses. For outpatient charts, start with the assessment or plan and then start again at the beginning. Look for diagnoses in the physical exam and the history of the present illness, not just in the assessment or plan, and always code to the highest level of specificity and follow your coding rules. I found a good article on the AAPC called Include Meat in Your Risk Adjustment Documentation. Include meat in your risk adjustment documentation. And what I loved about it is it said here that the more of a burden the disease is, the higher risk adjustment score is. Healthier patients have a lower risk adjustment score. So I thought that was interesting because that's really what it's going to all boil down to. Only diagnoses that map to an HCC are used in risk adjustment scores. And it says there are more than 9,000 ICD-10 codes that map to 79 HCC codes in the risk adjustment payment model. And so it talks about how MEAT helps you find that documentation to justify the risk adjustment scores. And MEAT stands for monitoring, evaluating, assessing or addressing, and treating. So just like you had your previous SOAP notes, with MEAT, monitoring are your signs, your symptoms, your disease progression or your disease regression. Evaluating are your test results, your medication effectiveness response to treatment. Your assessing and addressing are your orders, your tests, your discussion, your reviews of your records, and your counseling. and then your treating or your medications or your therapies and other modalities. So you have your meat that you look for in your risk adjustment. You also have your behavioral chart and your axes 1 through 5, as well as your SOAP notes. So again, these are documentations formatting that you can look for when you're doing your risk adjustment coding. Okay, guys, hope this information helps you with your risk adjustment coding. All right. Thanks. I will see you in the next one.